So we change of tack now on to three of the presentations. I hope everybody's had a chance to look at the poster presentations, number of abstracts, and then the top three were selected for an oral presentation. So each individual has got 8 minutes to chat, and then there'll be 2 minutes for questions. So do you have some questions for them? So I'd like to invite Rob Burdon up first of all to talk about his GA checklist. Thank you.
Hello, am I audible? Yeah, fine. Right, so my name is Robert Burdon. I'm a CT3 at Leeds at the moment. This work was done at Pinderfields with Sarah Kellner. So, the purpose of this presentation is to outline the implementation process, including the creation, refinement, acceptance procedures, rollout, and positive things we found out, and some issues that we encountered with the view to what we would do differently next time. So, the problem statement is that Pinderfields is a busy unit with approximately 6,000 deliveries a year, with a range of different case acuities. Included in those are emergency general anaesthetics, which occur on average once a week, often out of hours, when the unit is more likely to be staffed by junior trainees. It's important to acknowledge there is a latent potential for error here, which arises due to a combination of factors: nights, inexperience, and emergency. This is why NAP4 recommends the use of checklists, particularly when anaesthesia is performed in remote sites, as does the OAA advocate for their use during general anaesthetic. So we set out to create a checklist to mitigate against some categories of avoidable problems, such as human error, which is the greatest contributor to most hazards in safety-critical industries. There's always a temptation to create another checklist, more steps, more bureaucracy, so we must ask whether checklists are the right answer here. Factors that make this situation amenable to a checklist are that they prompt junior trainees, but to be clear, they're not to replace knowledge or experience, but avoid omissions. It's a stressful scenario, which is exactly where decision aids are helpful, and they're infrequently performed, so staff have to get out of their usual pattern. Different equipment needs to be ready, such as capnography. The main factor that makes this situation resistant to a checklist are obviously time pressure due to maternal or fetal circumstances, which understandably creates a reluctance to do anything that appears to create a delay to the surgical start time. Effective interventions are inherently multidisciplinary here, because they require good communication between all the teams at play. So we started with the knowledge that there are existing checklists in the region. However, we felt these wouldn't work if we directly applied them to our labour ward due to the specifics of how these work there. So instead we looked at these and selected elements that would be useful, borrowing heavily from Bradford's checklist, because that's where Sarah's also worked before. We styled that checklist as a call response, borrowing from the aviation industry, that is a dialogue between the ODP and the anaesthetist, which keeps us honest and makes it harder to gloss over tick boxes without giving them much thought. We then went through several rounds of feedback to see what anaesthetists wanted from the checklist and whether there was really any appetite to use it, and then approval from other members of the ODT. So in the survey, we found that about half of people were using some sort of mnemonic in their heads already, which is exactly what we want to reduce reliance upon. There was a full range of opinions on whether people would be helped by a checklist. Those in favour mentioned preventing overlooked steps and equipment, improving situational factors, such as task focus, having a quiet room and protected time. Those against said that they're time-consuming and create repetition, add pressure to a situation, and clinical experience can negate the need for one. We took that on board. The key point here is that those who have adequate confidence and experience are not obliged to use it, but it's there for those who want it. The reviewing process led to small changes which I think meaningfully improved the checklist, such as matching drugs to local practice, changing the order of points, and ensuring that the checklist occurs once pre-oxygenation has started, so as not to add time to the sort of critical path. The introduction of the checklist involved people, systems, and things. We coordinated a start date, communicated the existence of the checklist with the midwives, head of obstetrics, as scrub team and ODPs. We involve members of the theatre team to champion the use of the checklist and perhaps prompt new trainees to look at it. We implemented a feedback system via QR codes on the checklist itself and posters in the anaesthetic office so we can continue to improve it and monitor its use. And it was also announced at the safety brief process and in the prompt training. Then on the start day, all we had to do was put out the actual materials. So the checklist has been in place for 2 months at Pinderfields now and seems to be going well. Positives that we've identified are the focus on the team and communication element. We like the question response model and have found that everyone who's used it has had the protected time to go through it, which is great. We've also had positive feedback on the checklist itself. Those who've used it felt it improved their confidence. We think the design process is also robust and can be used elsewhere. Not everything went perfectly though, so if you're considering repeating this process, I would recommend directly addressing these points from the start. Culture change is challenging, and while the checklist has been accepted by the wider MDT, we would like more engagement from the other teams. We think perhaps it would be better to have an in-person group discussion where people might be more willing to raise concerns and suggestions, but recognise this can be really hard to organise. We also wonder if because this is a proactive change rather than a reactive project, it might be harder to achieve culture change here. Looking at our feedback process, we've not highlighted that everyone can fill this in rather than just the anaesthetist. We're working on getting meaningful feedback from the whole MDT as we think it would be helpful. For example, do the obstetrics and midwifery team think this checklist hinders progress, or does it make more sense what we're up to during induction? Finally, while we do have some responses, we don't actually have as much data on usage as we anticipated at this early stage. We tried to make the questionnaire short to negate this, and we knew it would be difficult to collect prospective data on a rare, unpredictable event. But even allowing for this, the response rate doesn't match the general anaesthetic rate. This can be explained to an extent by the fact that not everyone's going to use a checklist, but we still think it might be useful to cross-reference data on all general anaesthetics and approach those and ask them non-judgmentally whether it's situational factors or personal choice that influence their usage. We think there might be something to address there. Thank you very much. That's the end of my talk. Any questions?
Thank you very much, Rob. Any questions? Yeah. Ed will bring the mic to you.
Hello, it's Paul from Leeds. If you've decided that a checklist is a good thing or will improve practice, is there a rationale that everybody should use it for every GA? And this will also address your practice that a culture shift is required. So consultants leading by example, demonstrating that everyone is susceptible to gaps and errors in their practice and should use appropriate checklists.
Yeah, I certainly think an argument could be made for that, and certainly in other fields such as a critical care intubation, we see the checklists are used reliably, approaching 100% of the time. However, I think perhaps sort of cultural factors and existing practice has made that more difficult to implement. And also the time-pressured nature means that I think unless the checklist is done well, it can be quite hard to implement it in a way that is satisfactory to everyone who would use it.
How has buy-in been with your consultant colleagues?
So we have some feedback from consultants. Some are in favour of it, some haven't used it.
Very diplomatic, thank you.
Rob. Hi Rob. I'm Sarah Wood. I'm a consultant obstetrician. Am I the only obstetrician? I'm not the only obstetrician in the room. Might be one of you. So I'd like to, before I give you a question, I'd like to apologise for the cord prolapse, the bleeding, all the other stuff that we caused. Thank you for a really nice presentation. Feedback's really important. And have you had feedback from midwives, obstetric colleagues? Because it's really, when you're giving a GA to a woman, and you know this, you're the one, it's the loneliest place to be in the world, isn't it, when it's really challenging. It's a bit like this with the shoulder dystocia. It's you know, it's your it. What's your feedback been from the rest of the theatre staff, etc.? I suppose it will come when you have a face-to-face MDT, but have you had any initial sort of unofficial feedback from people about it? Thanks.
The midwives I've spoken to about it are in favour of it, and I think the obstetrician I've spoken to, once they understand it doesn't delay the critical path to surgical start, are also in favour from a safety perspective. I know the ODPs and theatre team quite like it as well, but I think they're sort of perhaps are more anticipating a checklist at that point than other specialties. What do you think, Sarah?
I think keep plugging away, and I am absolutely all for changing culture, because I think behaviour at the top of the tree will influence what happens further down. So I say plug away, and we need to role model as consultants and leaders. We need to role model the behaviours and the sort of inclusion that we expect everyone else. So keep plugging away. Well done, Rob.
Thank you.
Thank you, Rob. Our next speaker is Johnny Pyatt, who's going to talk to us about complex headache.
So, hi, my name's Johnny. I'm a CT4 anaesthetics trainee, and as I say, I'm going to talk about headache. It's just a bit wordy to say all that straight away. So, I hope you've had time to digest your lunch so we can tick off the differential of postprandial slump. This case presentation is intended to take you through a case of a cerebral venous thrombosis, post-dural puncture in a patient who also had Bell's palsy. I'd quickly like to say thank you to Dr. Sanjay Odd and Dr. Kay Robbins for all their support with this project, and thank you for coming today and all the talks that have happened so far. So, just at the bottom here, I've just included a differential for headaches in pregnancy split into primary and secondary, reminding you that primary is 20 times more frequent than secondary. The case we're talking about is a late 20s patient, who's 37 weeks pregnant, primate, low risk, BMI of 20, who presented with a 3-day history of one-sided headache. We requested a review in triage, and on review, she reported right-sided ear pain with blurred vision, and she said that her face was deformed. There was some neuroimaging performed, urinary PCR was normal, blood pressure was normal, and ENT came and said it was atypical Bell's palsy, and she was started on a course of steroids. Obviously, that's not in my differential, so just as a brief reminder, Bell's palsy is an acute unilateral facial nerve weakness or paralysis of rapid onset defined as less than 72 hours and unknown cause. Causes are theorised to be due to dormant viral infection, secondary to things like varicella zoster, herpes simplex, autoimmune causes, and also due to trauma. Sorry, that should have come up. In terms of diagnosis, it needs to be a rapid onset. It's usually facial muscle weakness on one side, but can be both sides, and there is effect on both the upper and lower motor neurons, so there is no sparing of the forehead. There can be ipsilateral ear and post-auricular regional pain, which is why it comes as a headache mimic, and classically patients complain of the effect on them, which tends to be articulation issues, drawing issues, or just the aesthetic of looking in the mirror. If anyone wants to ask, you can just Google it. If you Google Bell's palsy, she does come up. I hope you recognise that. So, the management is steroids as mentioned, and we usually expect resolution within 3 weeks, otherwise an onward referral is indicated. So this patient actually came back less than 1 day later with a spontaneous rupture, not in established labour, offered augmentation, requested an epidural prior to augmentation, which was performed, and complicated by an accidental dural puncture. There was a catheter placed, and it worked very well for analgesia and subsequent anaesthesia for a trial of forceps. And afterwards, the catheter was removed, prophylactic low molecular heparin was commenced, and she was sent back to the ward. On routine review, she had a postural headache. In light of the recognised accidental dural puncture, she was offered an epidural blood patch, which worked well. In 4 hours, she was completely symptom-free, and she wanted to go home. She came back. Same postural headache, recognising that she had an accidental dural puncture and the epidural blood patch had been successful. It was repeated, and again, within 4 hours, she was already home, very comfortable. She presented again, this time with a different headache, and the neuroimaging that had been performed 6 days prior was repeated, and it showed this. So one of our radiologists has very kindly put an arrow on there, but this is a high-volume dural venous sinus thrombosis with diffuse meningeal thickening and enhancements. So I did a bit of reading. By and large, CVSD can be referred to as a DVT of the brain. It has a widely variable presentation as it depends where the clot is and what's associated with the clot, be it hemorrhage, raised regional intracranial pressure, or hemorrhage, or edema. Most common presenting symptom is headache in over 90% of patients, and this can be the only feature in 1 in 4 patients. It's common in women and 15 to 45 age group, so we need a high index of suspicion, and we need to consider it where we've got even a recognised accidental dural puncture. If the character of the headache's changed or you've ruled out something like a subarachnoid hemorrhage, you need to think, could this also be a CVST? Risk factors include being in the puerperium, systemic inflammation, neighbouring site infections such as sinusitis, and low CSF volume. So, diagnosis, the best one is NMR venogram, and then management is any sequelae that are occurring, such as seizures, would be managed as normally, but there is no value in prophylactic antiepileptic drugs. Otherwise, it's anticoagulation, and the choice is warfarin. So, our working hypothesis is that the venous sinus thrombosis was secondary to intracranial hypotension consequent upon a CSF leak at the site of the epidural injection. Obviously, recent pregnancy and Bell's palsy would also contribute to a hypercoagulable state. So, point 1, should we have repeated the imaging earlier? So we had a definite recognised accidental dural puncture, we had good effect from our epidural blood patch, and the nature of the headache hadn't changed, and we actually had normal neuroimaging from the presentation with the Bell's palsy in the first place. So I think it was reasonable of us to repeat the epidural blood patch, in that we know that after 1 patch you've got success rate of 60%, and after 2 it's upwards of 85%, and this was otherwise a low risk patient. What we didn't consider at the time was the intracranial hypotension. That wasn't something that was in our minds, and I think in the future that would be. Otherwise, should we have started anticoagulation earlier? So anticoagulation was started after the instrumental delivery, and I'll talk a little bit about that. So obviously Bell's palsy, unknown cause is the key point of the definition, but we think it may be related to some sort of virus or autoimmunity, which could indicate a procoagulable state. There was a narrow window between the diagnosis of Bell's palsy and the presentation in labour, so initiation of any low molecular heparin might impact the decision for regional anaesthetic or general anaesthetic, both analgesia and anaesthesia. She was low risk, and we can look at the RCOG green top guideline in terms of risk factors. So those are the pre-existing risk factors. I think you can see most of them, but basically she didn't tick any of those boxes at all. In terms of obstetric risk factors, I think, I had to check this one, but I think rotational operative delivery is forceps delivery. You can check with any obstetricians in the room. But yeah, so they went in and they rotated, is my understanding of that. And then there was the new onset was transient symptoms. The only one that's kind of up for debate there is the current systemic infection, although she did not require IV antibiotics or admission to hospital. So the guideline is quite clear that every woman should have a risk factor assessment, and that should be repeated on any admission or any change to her medical comorbidities. It should be checked postnatally, and all of that occurs. And then the advice in terms of warfarin is that it's safe from 5 to 7 days once the risk of bleeding has reduced. In terms of DOACs or NOACs, currently no guidance on them. And that's just to say that we did the intermediate risk. This is actually all one slide, it's just got a lot of animations because my wife allowed me to borrow the laptop. And then in summary, very unfortunate patient. Those are some of the kind of numbers, and we just need to stay cognizant of the cumulative effect of all the things that come into play in an already prothrombotic patient group. And I would say consider CVST if you've got 2 epidural blood patch, even if you've got a recognised accidental dural puncture. And then MDT involvement and early repeat imaging is key to good outcomes and follow-up. She did all right, she's absolutely fine. Thank you very much.
Thank you very much for the presentation. Anybody got any questions on the floor? Ed?
Is there any association between blood patches and developing one, or is it just an actual puncture itself?
So I do have some references, but I don't think you can see them. But what I did was I had a look through and I found a few case reports which link mostly lumbar punctures and accidental dural taps, so the kind of intracranial hypotension. There were a couple that seemed to indicate that maybe epidural blood patch was a risk factor, but there wasn't a comprehensive evidence base for it. It was single case reports. And then there was one single case report in a Jewish kind of university thing that I couldn't really quote very well, which showed a lady with Bell's palsy who got a CVST. So there's a paucity of evidence / case reports.
Sarah?
So we wouldn't generally do a epidural blood patch until about 48 hours after onset of symptoms. So are your guidelines to ensure that women who are on bed rest do get prophylaxis during that period of time? Because obviously we need to time it for the blood patch, but these women are at risk of thrombosis whilst they're on their bed rest. Is that written into your guidelines?
I'm not sure if it's written into the guidelines. This lady kind of had everything occurring almost day by day. So she presented with early symptoms of Bell's palsy, and she actually self-discharged because there was a delay in medical review. She represented with more advanced obvious symptoms, had her diagnosis including her imaging, represented again in labour, progressed through her labour, and then during, I think she gave birth overnight, and then during that day was when she developed a postural headache, tried conservative management, was offered it and received the epidural blood patch in the evening, and then kind of came through. So there wasn't so much more time, it was more that it was a recognised accidental dural puncture with an epidural needle with an incidence rate of upwards of 75 to 80% of post-dural puncture headache. I think we just went ahead with the epidural blood patch.
You mentioned about in the top guidelines about the coagulation screen. Did she have a
Do you like the microphone? Sorry, it's just beside you. Thanks.
Did she have a coagulation screen done?
She did, yeah, and it was negative. So CVST, there's up to 30% of these patients do have a thrombophilia, but her thrombophilia screen was negative.
Thank you very much.
That's it. Thank you very much. I mean, Sinead on here. Okay, thank you very much. Great, so our final presentation in this section is from Kelly Sugden, who's going to tell us about her analgesia. Perinatal analgesia. The old president wasn't as... I must say.
Hi, good afternoon everyone. My name is Kelly Sugden and I'm here to talk to you about Perinatal Analgesia Week, and this is a project that I organised last year at Bradford during my ST6 year, and it was held in January of this year. So what is it? It was a week dedicated to promoting the awareness of perinatal pain and its treatment. It encompassed some MD teaching and training. We hope to interact with some patients and provide some patient education and information. And we also wanted to take the opportunity to provide some pump training on the new epidural pumps. So why is it needed? Bradford Royal Infirmary serves a medically complex and culturally diverse population. In a recent census, it showed that 30% of the population of Bradford are Asian or British Asian. 57% of households are classed as deprived, and the Bradford district is ranked as the 5th most income-deprived local authority in England. and it's the second most income-deprived region in Yorkshire, only second to the city of Kingston upon Hull. As we've already heard today, the recent Embrace report demonstrated inequalities in maternal mortality. So if you are an Asian woman or if you are a black woman, you are more likely to die during childbirth or the perinatal period compared to a white person. For women living in the most deprived areas of the country, they are 2 times more likely to die than women living in the least deprived areas. Last year in anaesthesia, there was a cohort study published which showed that black and Asian women had lower rates of neuraxial analgesia when delivering vaginally. And Safely Delivered, a report published in 2014, looking at patients' experience of maternity care, showed that women from ethnic minority groups were more likely to suffer poor communication and be shown feelings of disrespect from staff. So, we did some preliminary audits looking at pain scores and prescribing, and we found that we were performing quite poorly. So 67% of our patients reported moderate to severe pain post-caesarean birth. Not one prescription that we looked at complied with our trust pain guideline. We took the opportunity to speak to midwives and survey them, and it became apparent that they received no teaching or training as a part of their undergraduate degree in pain, how to assess it or how to manage it. And as a part of these preliminary audits and surveys, we sought to work out what the barriers were to achieving good perinatal analgesia. We highlighted staffing issues, prescription issues, communication issues, and language barriers. So how did we do it? It took a lot of organising, a lot of speaking to different people and different teams, from matrons to managers to medical education, medical illustration, printers, the pain team. I spoke with the Spark team, so they're the spiritual, pastoral and religious care team at Bradford, and they were able to give me some insight into some of the cultural and religious beliefs our patient population has in Bradford. I sent out a WhatsApp plea on our trainee WhatsApp group in Bradford asking if people wanted to get involved in an obstetric project, and thankfully I got 7 willing volunteers. They helped with the T-trolley training, they helped with manning the patient information stand, they helped with designing the logo and posters. So we advertised the event in the maternity department, and we also advertised it on the maternity social media pages. I contacted Bradford Hospital's charity and asked for them for some funding to put on the week. We also designed a 15-minute presentation to teach midwives about pain, the assessment of it and how to manage it, and then who to escalate to if necessary. We also included some of the cultural and religious aspects to this, and this was delivered on labour ward and postnatal wards in the form of T-trolley training. And then for a week we had this stand in maternity outpatients, and it was manned by an anaesthetist or an anaesthetic trainee, and it gave patients the opportunity to come of their own free will and talk to us about the analgesic options available to them during labour and after birth. And we had resources in various different languages and QR codes to various resources in different languages. So results and feedback. It was a difficult week staffing-wise. The unit was in escalation for several days, but despite that, we managed to provide T-trolley training for 30 staff members. 97% of which reported an improved confidence in pain assessment. 100% reported that they had more understanding about the medications they were administering, and 100% of people found the teaching useful. We received lots of positive verbal feedback from passing staff members, and 59 patients visited our stand in outpatients, half of which were primates. 88% of people who came up to the stand were interested in finding out about analgesia, and 70% of people specifically wanted to know more about epidurals. Recurrent themes were concerns over side effects of epidurals, mainly back pain and paralysis. We also designed and had printed these pain crib cards, and they were distributed to all midwives, and they can attach to their badge, and they have now their own individualised pain score or pain scale, which they can use to help assess pain in patients who there may be a communication difficulty or a language difficulty. We also had some badges made to encourage people to report pain. So what next? Bringing interventions together in a perinatal analgesia week really created a sense of momentum and enthusiasm for improvement. We hope to repeat this event annually and to embed an understanding of pain assessment and treatment into the unit. We'll continue to audit our prescribing and our pain scores to see how well we're performing as a team. We're currently in the process of updating our online resources for the patients, and we're also in the process of updating our obstetric analgesia guideline. I'd just like to take this opportunity to thank Bradford Hospital's charity for generously funding the week, my fellow trainees, Penny, Lucy, Alina, Kate, Mike and Ravi for helping me pull it off, and Fozia Pyatt for supervising the project. Thank you very much.
Thank you very much, Kelly. Any questions?
Sorry, Phil from the LGI here. You mentioned that patients' religious beliefs and cultural beliefs played a role in your education. What were some of the themes amongst those, just so that we can take that into our own practice?
Yes, so Bradford has a big Asian population, as most of you will know, and the predominant religion there is Islam, and a lot of our patients practice something called the knee fast, which is a period in the 40 days postpartum where essentially the lady who's given birth is looked after and cared for by her family, so she may not want to get up out of bed, she may not want to mobilise, and obviously you're at a risk of VT in this kind of in the postnatal period. So that was something that when we were doing the training on the postnatal ward with the midwives, a lot of them weren't actually aware of, and I think it's important for them to be aware of it when they're looking after these people, because that might be the reason why they don't want to get out of bed, or they're expecting, you know, to be kind of waited on. So yeah, I don't know how to say it in any other way, but yeah, so that was the main thing that the Spark team highlighted.
Thank you.
Got the microphone over here, Ed.
Yeah.
Oh, sorry, Andrew. Sorry, go ahead.
Hi, Kelly.
Hi.
I'm from BRI again. Well, that's a really good presentation. Thanks for that, Kelly. Just two questions. One, did you, the recurrent theme of the fact that paralysis and back pain, were you able to establish where patients were getting these impressions from?
Yeah, so they were actually getting it from kind of the community, word of mouth in the community, and also getting it from social media and TikTok apparently, which that blew my mind. But yeah, so community and social media.
And second question, we still have your information board under the desk in the office, and we've been told you're coming to collect it. We would like to move it.
There's been a failing there.
Just got one other question from the lady here, just blue shirt. Just the lady in blue.
Oh, sorry.
Hi, it sounds like a fantastic project. There was an awful amount of work for you and your trainee colleagues.
Yes.
I presume if you're on SD6, possibly now SD7,
Yeah.
so rotating away.
Yeah.
How are you planning on making sure that all of your effort with such an important project was worthwhile, it's going to continue to be maintained?
So I'm still in touch with Fozia, the consultant who supervised the project, and I still have some of my trainee cohort currently working at Bradford who are still working on the project, and we'll be presenting it at the joint anaesthetic and obstetric meeting, which is coming up shortly. So that's essentially how we're going to hopefully keep it running. And in fact, I think after my week in January, they're now doing a perinatal hemorrhage week in a couple of weeks' time. So it's really got some traction, and they're starting to do other things as well.
We time?
One last question. Hello. I just want to ask if you did any kind of research into what happened with the analgesia once they left hospital as well.
Because I know a lot of women get good algae, well, not good, but analgesia
Yeah.
when they're in
Yeah.
hospital, but when they leave it.
We didn't do any specific research about what happened when they left hospital, but we had a lot of conversations on the wards when we were doing the preliminary stuff. And it was really interesting to speak to some of the women because there was a lot of kind of misunderstanding about things, and they were in pain and didn't want to take medication because it would be passed on to the baby. So, you know, I've been in contact with the midwifery and parent education team at Bradford because we really need to kind of start at the beginning with education and make it accessible to people. So it's, you know, it's all well and good having a QR code or a leaflet printed out in a different language, but you know, there's a significant proportion of the population that can't actually read, and we talked about maybe doing some videos or some recordings in the kind of most common languages that we have in Bradford, but that's, you know, yet to get off the ground, but it's something that we've discussed and potentially can take forward.
Yeah, okay.
As a suggestion, have you thought about linking up with your maternity voice partnership representatives who are patient voices, and also working with your vulnerable midwife leads to perpetuate the work that you've started, but to keep it going? Because I think both of those links would be very valuable about reaching out, particularly to the communities that you're talking about, but also allowing the great work that you started to continue from the midwifery and maternity voice partnership. Because you want to reach out to those.
Yeah, we do. Yeah, I mean, it's something that we can look into and take forward. And also, when we were doing that week, the Spark team, who have a very big following on social media from the local population, they were kind of advocating our week and posting it on Twitter to encourage people to come down and get involved. So, yeah, it's something that we can take forward.
Thank you very much, Kelly.